And now our
Hi,
second
everyone.
talk is, well, you're already there, queued up. So I'll let you. I don't want to take up any of your time. I'll turn it over to you right away.
Thank you. So hi, everyone. I'm Marie Ferguson. I am a project director with PHICOR, which is headquartered at CUNY School of Public Health and led by Dr. Bruce Lee, and have been working with him for the last 6 years. Most of my work has previously focused on developing computational models for non-communicable diseases, largely focused on obesity prevention. But in the last year have been working with our team to do a fair amount of COVID modeling to answer a number of different questions to help with the response. So this study that I'm going to talk about today is looking at our study that explored the value of reducing the duration of the SARS-CoV-2 infectious period. So the motivation for this study really stemmed from wanting to understand if medications or vaccines that may have more subtle effects have value. We know that a lot of the public conversation in the news and media has been focused on vaccines that prevent infection or medications that completely cure the infection. And we understand that that's the ideal situation and what people are most interested in. But, there is the question that remained of, there are probably going to be vaccines and medications that emerge that have subtler effects. So what's the value of that? So one possible subtle effect that a medication or vaccine could have is, could it reduce the time that someone is shedding the virus? And if it does it, if it does, that would benefit the person, but it could potentially, reduce transmission in the broader population. So the question that we focused on was what may be the value of reducing the time that someone sheds the virus. We know that COVID-19 is a multi-scale problem that crosses the different interconnected scales. And so it's necessary to understand, how they're connected, how the effects at one scale could have downstream effects across other scales. And so that is what we aim to understand and address with the model that we developed. So this is the paper that was published in PLoS Computational Biology in January. And the paper essentially found that if you do reduce the duration of the infectious period, you can avert millions of cases and save billions of costs. So as I mentioned, we developed a multi-scale model, which represented the US population, the entire US population, so 327 million people, the mixing patterns of the population in a stochastic compartment model, and the spread of SARS-CoV-2, which we represented with an SEIR model. And then individuals that were infected in the transmission model then moved through a probability tree to basically simulate what would happen after a person gets infected. So this represented the probability of seeking ambulatory care or having a telephone consult with a provider, seeking or having to be hospitalized, and then other severe disease outcomes, which may have include ICU admission. And so as individuals travel through the probability tree and experience different clinical outcomes, they also accrued different costs in the form of direct medical costs and productivity losses. And then, of course, we represented the virus and different characteristics of the virus, including R naught, the infectious period, latent period, and relative infectiousness of asymptomatic infections. So since we were specifically looking at reducing the duration of the infectious period, we wanted to not just represent the infectiousness as equal across the entire duration. So there are several studies coming out that were showing that viral load was rapidly increasing prior to symptom onset, and then began quickly decreasing following symptom onset for the rest of the duration of symptoms. And these figures are from 3 different studies that show, they all show on the x-axis time in comparison to symptom onset, and then some measure of viral load. And as you can see, it increases prior to symptom onset and then decreases thereafter. So how we represented this was we essentially, using data from these studies, had 43% of transmission occurring by the peak, which was at symptom onset, and then 43% of transmission occurring between the peak of infectiousness and halfway to the end of the infectious period, and then further decreasing for the remainder. So the duration of the period was on average 9.5 days. There was a distribution, it varied from 4 to 15 days. And this did include, you could transmit and be infectious the day prior to symptom onset. We also assumed that asymptomatic infections were half as infectious as symptomatic infections. So in terms of what we simulated and the scenarios that we ran, so we did assume, like I mentioned, that the average duration of the infectious period was 9.5 days. And then we ran simulations that decreased that duration by half a day, 2 days, and 3.5 days, which then corresponded to an average infectious period duration of 9 days, 7.5 days, and 6 days. And how that worked is essentially, the medication or the vaccination that we represented reduced the infectious period duration by moving individuals to the recovered bin, the recovered compartment, at a faster rate because they were drawing from infectious period duration distributions that were narrower. And then we also conducted, so we looked at the, reducing it by these different amounts, and then also treating just symptomatic individuals and then all infections, and then varied the proportion of the population that received the treatment from 25% to 75%. We also varied when the treatment started. So whether it started after 5% of the population had already been exposed to SARS-CoV-2 or after 15%, and then varied it within there. We varied the total treatment cost and the R0. So this is the first result slide. So what this is showing is the reduction in cases at the peak on the y-axis and the average duration of the SARS-CoV-2 infectious period on the x-axis. So here you can see, so this is at 9, this is when it was the duration was reduced by just half a day. And then this all the way here is when it was reduced by 3.5 days. So even when we only treated 25% of symptomatic cases and it only reduced the duration of the infectious period by half a day, it still reduced the cases at the peak by 1%. If we reduce it by 3.5 days, it reduced it by up to 11%. And then when we treated 75% of all infections, and reduced the period by 3.5 days, it reduced the cases at the peak by 37%. So we can start to see that even just a really small reduction in the duration of the infectious period has an effect on cases at the peak, which is important, we know, because flattening the curve is necessary to make sure that healthcare resource use capacity isn't overloaded. And I think, since what this translates to as well is since the peak since when you reduced the duration of the infectious period, and there was a reduction at the peak, you're in essence also reducing herd immunity. So the proportion of the population that has to be infected to start seeing a herd immunity threshold to start seeing a downward trend in the epidemic curve. So this slide shows the cases averted in millions. And we can see that between 1.4 and 30 million cases are inverted when the infectious period is reduced by half a day. So even if it's just reduced by half a day and only 25% of symptomatic cases are treated, there's still 1.4 million cases that are averted. And that can continue to go up even higher as more people are treated and as the reduction is increased. The other thing we see here is that there isn't as much of a benefit as from expanding treatment from just symptomatic to all infections as there is to expanding coverage. So it's more important to expand coverage from 25% to 50% to 75% than it is to expand from just symptomatic to all infections. This slide shows the results for healthcare resource use. So this is the hospitalizations averted in millions and ICU admissions averted in millions. And so here we see that there are 3 million hospitalizations averted for when there's 3.5-day reduction in the infectious period when you treat 75% of COVID-19 cases, and then about 500,000 fewer ICU admissions, which saves greater than $757 billion in direct medical costs and productivity losses, assuming a $500 cost per treatment per person. The other thing that I didn't mention is all these results here are assuming an R0 of 2.5 and assuming that 15% of the population has already been exposed. So this figure summarizes the results. So we can see as the reduction increases more and more and more, the cases averted increases more up to 7.4 million. This is, or at least 7.4 million when 25% are treated. And then same with costs saved as the reduction increases more and more, we see hundreds of billions of costs being saved. So the overall takeaways from this study are that reducing the time that someone sheds the virus decreases the spread. So not only does it have an impact on the individual, but it also has an impact across the population, across healthcare resource use, across their economic benefits to it as well. So I think one of the things we found is, capturing and understanding what's happening in terms of the virus, not only at the individual level, but across the population is important to really understand the downstream and the downstream effects of that. We see that even just reducing the duration of the infectious period by half a day and only treating 25% of cases reduces millions of cases and saves billions in costs. And so this can also help benchmark for researchers who are developing these medications and treatments. There may be the tendency to think that, a medication or vaccine that only reduces the duration by half a day isn't worthwhile, but we see that that's not the case, that there are still a lot of benefits that can be gained from that as well. We also see that if there's less time to transmit the virus, there are fewer cases generated, and therefore there is a reduction in the herd immunity threshold. So for example, we saw that reducing the duration of infectiousness for 25% of cases can lower the peak of the epidemic curve by 1 to 11% and avert up to 11 million cases. This can also, the cost savings that are outlined and quantified in the study can also help, strategize how much to invest in the development of certain vaccines and medications, and also, help plan for potential different rollouts of medications and treatments that emerge that are have subtler effects. So in terms of multi-scale modeling opportunities, we are interested in continuing to develop and refine and add more detail to different scales of the model. This includes having more detailed representations and characteristics of different variants that are emerging, incorporating the effects of seasonality into the model, having more specific representations of viral shedding over time, and more detailed representations of different transmission pathways, such as aerosol transmission or transmission that occurs in the environment. And this is our team that everyone participated in developing this model. So definitely a team effort. And that concludes the presentation. So happy to answer any questions. And I think Dr. Bruce Lee is on the call as well. So if he has anything to add, can give him a moment as well.
Yeah, thanks, Marie. And thanks for presenting that. Just to add, so Marie's been heavily involved in doing a lot of non-communicable disease multi-scale modeling, but our team and only recently over the past year or so has ventured into COVID-19 modeling, but our team in general has been doing infectious disease modeling and epidemic modeling for the past 15 years or so. So some of the folks that she showed there have been working on these issues or problems for well over a decade and a half.
Lovely. Thank you both, for especially given how complex your subjects were, for keeping it in such a short amount of time. As usual, we wish there were more time to hear more detail. I hope both of talks suggest new collaborations. It's very interesting to see the financial and economic consequences considered in the model, and that was nice to see. So we have time now for a few minutes of questions. Again, I encourage people who haven't asked a question yet in this forum, please don't be shy and speak up. We know there's all sorts of expertise in the room, and we'd love to have your points of view. Does anyone have a specific question for either of our speakers?
Yeah, well, I'd like to make a question. That's okay. Okay, I'd like to ask Tom Helliker, what kind of experiments you do to verify your models and the results?
Yeah, so that's a good question. So it depends on the scope of the model. And the biological questions, or that drive the reason why we're building the models to begin with. In a recent paper of ours, I can share the link in the chat in a bit. We built multiscale, we built genome-wide metabolic models of CD4 positive T cells, the different subtypes. And we were in particular looking for existing molecules or FDA-approved drugs or molecules that are in clinical trials that could be potentially repurposed for 3 different autoimmune diseases. And so when we build the models, we use the literature as a way to validate the behavior of the models, but then we also when we have the resources, we go to the point where we test experimentally, at least in vitro, some of the predictions. And so in that particular paper, we were able to test the effect of 4 or 5 different drugs on T cell proliferation. And so it depends. Models are, computational models are much like animal models. They're just models, right? And so they won't be perfect. And so we have to, as a community, figure out the best way to communicate the accuracy, or it's not about accuracy, it's really about the usefulness of the models, right? And so is the model able to help you answer the question that you're after? And so it's a mixture of comparing your output to the literature, to independent experiments, but also to your own experiments if you can.
Okay. Thank you.
Other questions for either of our speakers?
I have a question.
Please go ahead.
To Marie. So actually I have 2 questions. So the first one I probably missed, but what assumption was made regarding the susceptibility to infection? Was it assumed the same for all people? This is the first question. And the second question, some data suggests that actually asymptomatic people, they shed virus longer. So did you try these different scenarios in your model? Maybe people with mild infection also will shed the virus longer.
So we assumed that there was homogeneous mixing across the population, across the entire population. So there, in that sense, it was equal probabilities of being infected. We did have age-specific probabilities of different clinical outcomes. So there were different age-specific probabilities of being, seeking ambulatory care, being hospitalized, and proceeding to more severe outcomes. And then in terms of the assumption about the asymptomatic, so we assumed that asymptomatic infections were half as infectious as symptomatic infections. So 50% less infectious. So that was a conservative estimate based on what we found in the literature. We didn't have a difference in terms of the durations between them. But yeah, so the asymptomatics were half as they're half as infectious. And so if they are just as infectious, we would have seen even greater reductions in cases averted, cost savings, et cetera.
We did account for different levels of transmission based on using distributions for R naught. So there is variability, and so we do represent variability in transmission.
Okay, thank you.
Reinhard, do you have any general business we want to cover before the end of the meeting today?
Not really. I was counting on more questions.
Okay, then by all means, let's continue the questions. I just didn't want to cut you off if you had general business.
No, I only have one remark, which takes 30 seconds. So let me just make that. As you know, most of the business that's getting done and most of the work that's getting done is being done in the subgroups. So if you have not signed up for a subgroup yet, I would very much urge you to do so. There is a large number of them available, so there should be one with a flavor that fits pretty much everybody's taste. So please sign up. That's it then, James. Thank you.
Okay, we have time probably for one last question for our 2 speakers. Anyone have a burning question to ask? They both kept to time, so we have time for another question. Well, if our non-usual suspects don't have questions, I will unmute our usual suspects. If our usual suspects have questions, that's fine now too.
I have a question for Tom.
Please.
So, Tom, you mentioned a lot of annotations. specifically, is the idea to make it as traceable as possible to the source of the data? Is this the usual use of annotations, or do you use them for something else? Meaning traceability?
Yes, so I look at it as, so when I say annotations, a lot of the community focuses on annotations related to IDs, like, you know, what is the gene ID of this component, and the other ontologies and things like that, and those are extremely important. But where I feel like as a community we're missing an opportunity, or I personally feel like there's not enough of, is providing the evidence as to why this interaction between two different components even exists in the model. It could be that interaction is an assumption by the model creator, or there is evidence, biochemical experiment that was done that shows that interaction does exist. But either way, wherever it's coming from, I think there needs to be more of including those in the model. So the purpose, the reason why we've created it is that to understand why we're even putting those interactions in there, and be able to trace it back as to how it fits into the system.
I guess I'd like to make a sort of a comment / question, violating my rule about not talking, which is that we have a lot of tools for designing pathways, and we have tools for executing stochastic models, probabilistic models, rule-based models. But we actually have very few tools for building what I would call either qualitative, or, to be more technically correct, conceptual models. And it's the conceptual models that is the pathway, for example, that are portable and reproducible. And so having a tool that gives you support for annotation and model structure construction, even if there were no execution, is already very valuable. And so to me, actually, the thinking about optimal ways to do conceptual model development and presentation is something that's a really undersolved problem in computing and model building. And so I think what you've done here is very impressive. And I wonder if you have any ideas about how you might be able to extend that beyond network models to other kinds of model structures.
Beyond, well, what other model structures are you referring to?
Well, of course, interactions could always be thought of as an arrow of some kind.
Mm-hmm.
But for example, the kind of multiscale model that we heard about in the second talk, or the spatial models that we build, these are where if you have something like cell adhesion or movement of individuals in
more
a population.
physics-based, yeah. I mean, it's possible, and I hope one day we'd be able to do that, and in collaboration with your tools and the tools that already do it really well. It's I don't want to reinvent the wheels in particular on the simulation and computational side of things. In some cases, because it is a web-based platform, the disadvantage that we have from the command line tools is that every feature that we want to expose to an end user has to be developed in, the user interface has to be developed for that. And so that is very expensive for us to do, because it requires, much more man hours to develop. And so, and another aspect is web-based platform is great because it unlocks all this collaboration, but it's also very expensive when you have thousands of users trying to solve a constraint-based model or optimization problem against your server, or servers. And so, we've been solving that a lot by bringing the simulations into the web browser. And so all of the real-time simulations that you see in the logical model, that's all done on the user's browser in JavaScript. And so we can serve thousands of concurrent users without any strains. And so those are also additional things we have to consider when bringing in additional, features and modeling approaches.
Okay, thank you very much. I'm afraid as usually run out of time. I hope people make new connections from this meeting, and I look forward to seeing you tomorrow for the steering group, and then next week for our speakers. Thank you everybody for your patience and your participation, and very much thank the speakers for doing such a great job presenting complex material in a very brief amount of time. Thanks to everybody.
Thank you.
Thank you all.
Thank you.
Take care.
Take care.